Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. Arthroplasty is a surgical procedure to restore the function of a joint by replacing diseased and damaged parts. Not everybody is made the same way, and so when it comes to complex shoulder and elbow surgeries, 3D anatomical modeling can be used to help the surgeon plan the surgery for better outcomes. Joining us to discuss this today is Mayo Clinic orthopedic surgeon, Dr. Mark Morrey. Dr. Morrey, thanks for joining us.
Thanks for having me.
So Dr. Morrey, as a shoulder and elbow surgeon, tell us about the common problems that you see in patients.
Well, as you pointed out in the introduction, arthritis is a common problem, and that can be caused from a systemic disease like rheumatoid arthritis, or more commonly today, when we're replacing the joint, trauma or the sequela of trauma. So the joint becomes damaged due to an injury the patient's had and needs to be replaced because of severe destruction to the joint afterward. But we deal with tendon disorders as well, ligament disorders. So around the elbow, it's a really very highly congruent joint, meaning that it fits together like a puzzle piece. And when the puzzle pieces aren't quite fitting right, you can't really smash them together and get them to fit just like a puzzle. And so in those situations, either we need to reshape the joint or fix the incongruity or instability that might exist. But those are common types of problems that we deal with around the elbow, and the shoulder similar. And the shoulder is similar with arthritic change or post-trauma, or in the shoulder more commonly primary arthritis is really the main disorder that we're dealing with, where wear and tear arthritis, where the shoulder needs to be replaced.
So when it comes to the shoulder, we see a lot of patients who have what they call rotator cuff problems.
Mm-hmm.
And you mentioned tendons. Can
Mm-hmm.
you mention what's the difference between a tendon and a ligament, and what is the rotator cuff?
Great. That's a great question. So a lot of people call it the Rotary cup when they come into the office, but it's a cuff. It's a sleeve of tissue of four tendons. The rotator cuff is, and the four tendons are there's one in the front. It's called the subscapularis. There are two sort of that are on the top, the supraspinatus and the infraspinatus, and then one in the back of the shoulder called the teres minor. And those four tendons are connected to muscles, and they help to power the shoulder. Their job is to really hold the ball of the shoulder. It's a ball and socket joint, very shallow socket, but their job is really to hold the ball against the socket. So the great big muscle of the deltoid can help power the shoulder. It provides a fulcrum so that it's not pulled up and out of place. And those are the tendons because they're connected to the bone on one end and then the muscle on the other, and have dynamic power. The ligaments are the soft tissue structures that are connected from bone to bone and help to confer some stability to the joint so that it's not so that it doesn't dislocate. So while tendons connect muscle to bone, the ligament really connects the bone to the bone.
And so when you said about the rotator cuff, is that when patients say that they, for example, when they sleep on their shoulder at nighttime, it hurts them, they can't get in a comfortable position, or they have difficulty raising their arm, putting
Sure.
a shirt on, for example?
Yeah, that's probably one of the most common conditions that we treat is rotator cuff problems around the shoulder. And really that hurts patients once they get up around 90 degrees. They have trouble initiating their initial movement, but it really hurts them when they get to with their arm just away from their body. So when they're doing things away from their body, like picking up their kids, for example, it's common, or when their arms are out away from their body. And then, as you mentioned, sleep. So when you're not sleeping well, that's oftentimes the primary reason that patients come in to see a physician, just because it's just so disruptive not to be able to sleep well. And unfortunately, we lie on our shoulders, and rotator cuff problems frequently cause dysfunction with sleep.
So if you're diagnosing somebody with a rotator cuff problem, is the treatment surgery, or are there other things you can do before surgery?
Depends actually on how the rotator cuff was injured. So if the rotator cuff was injured with an acute fall, like they fell on their shoulder and they knew the moment that they injured it, that is most often and most successfully treated with surgery. Whereas that's not the majority of the rotator cuff injuries we see. The majority of the rotator cuff problems are sort of wear and tear over time, and I like to tell patients that this is more of a rotator cuff wear versus a rotator cuff tear, where it got torn from the bone. And it's a subtle distinction, but it's important because it matters whether or not you offer surgery and when you might offer surgery. So many of those patients that have small rotator cuff tears or rotator cuff wears that are really degenerative in nature can oftentimes do quite well with physical therapy and maybe an injection to decrease inflammation while they're participating with therapy. And don't necessarily go on to surgery. If they don't do well with those types of interventions, then we do consider surgery, but it is not the first go-to. Whereas if they've traumatic ruptured the tendon, then we're more apt to go to surgery. It's more like a broken bone in that instance.
And as time has evolved, surgical techniques have improved. When you're doing rotator cuff surgery, how is that different now to how it used to be, for example, 10, 15 years ago?
Uh, Great question. So now we do mostly keyhole surgery or arthroscopic surgery where we're making small incisions around the shoulder and using a camera to look into the shoulder to use instruments to fix the torn tendons. And we use things like anchors that you might be familiar with, like putting in a wall anchor at home, from Home Depot, and they're very similar to that. They look like little screws that have strings that come out that help us to lasso the tendon and sew it back down to its where it belongs. And prior to that, we did a lot of open rotator cuff repairs where we make an incision on the skin, so the recovery might be a little bit longer, might be a little bit more prone to getting stiff after surgery. But we would then put sutures in the traditional way through an open approach where you're looking directly at the tendon and passing the suture through the tendon and then through the bone and then tying it. So it's a little bit different, and the skills required to fix one way are very different. Arthroscopic skills are different than the open skills, but it's been an advancement, I think, in terms of our ability to get patients recovered slightly faster with arthroscopic approaches.
Now, Dr. Morrey, in terms of getting our patients back quicker and safer, you've always been a pioneer in surgical treatments. And so, for example, a common elbow problem is tennis elbow or lateral epicondylitis. Can you tell us some of the innovative ways that you're treating this now?
Sure. So, that's also undergone a major evolution in our thinking and the way we treat it. So it's the most common reason that patients present to the doctor's office for lateral elbow pain is tennis elbow. And it's a tendon degeneration. So it's unlike a rotator cuff injury where you fall on it and rip the tendon off. This is really an overuse. Is probably the best way to think about it. The tendon becomes brittle and tears or has these little microscopic tears in it. And for whatever reason, the biology just doesn't get it to heal. And so one of the most common ways that we treat it right off the bat is with therapy. There have been several randomized controlled trials on a specific type of therapy called eccentric strengthening. And we always start patients with that, and that has a very high likelihood of helping patients and getting them to heal. If that doesn't work, then surgery is offered. And surgery used to be an open procedure where we make a small incision and scrape the tendon, clean the tendon, and try to elicit a biologic response. Try to get bleeding so that there was a scar so that the tendon could heal. And then we evolved and started doing that arthroscopically if surgery was offered. And then more recently, we can look at the tendon under ultrasound and very precisely see the tendon lesion, and using an ultrasonic probe, we can do the same thing that we could do arthroscopically, where the probe vibrates at a certain frequency, and for lack of a better word, will aspirate or remove the tissue, the diseased tissue, and just very similar to open or arthroscopic approaches, that sets up a biologic healing response. So that's been a new innovation in the last decade that's really helped us to treat patients with sort of recalcitrant tennis elbow symptoms that just aren't getting better with physical therapy.
And how's the rehabilitation with the ultrasound treatment different, say, for open surgery?
Well, it's faster. So I'll institute or initiate eccentric strengthening exercises for patients at 3 weeks following that procedure, whereas it might be up to 6 weeks or 2 months for an open approach. So it's a little bit faster. And patients don't have to be put to sleep, so they don't have to undergo a general anesthetic. It's a local anesthetic, so their recovery immediately post-procedure is much faster.
Now, one of the things that you mentioned earlier on is how treatment of the elbow can be unpredictable. And I understand that you've been using new 3D modeling to try and help you understand, teach, but also treat patients differently. Can you talk to us a little bit about your experience with that?
Yeah, I would say that in the last decade, this is probably the one area that has revolutionized our understanding and our ability to treat really complex deformities around the elbow. And you know, a picture is worth 1,000 words, a video is worth 1,000 pictures, but when you're holding a model in your hand, that's worth 1,000 videos. And it really has increased our understanding of the pathology that we're going to treat. It's changed our approaches in many cases to how we're going to treat elbow disorders, particularly in patients who have undergone multiple surgeries previously, may have had an elbow replacement in the past and now have lost tremendous amounts of bone, and we need to reconstruct their bone with donor tissue, cadaver tissue, bone that the implant is then going to be implanted into. And this really helps us to precisely cut, measure, size, and have better outcomes because we have better junctions, more precise ways of joining the bone back to the patient's bone.
So how do you create these models?
So it's a really a partnership between the 3D printing lab, which is run by Jay Morris, who's a radiologist, and the patient will have a standard CT scan, and then they are able to take those images and go through a process called segmentation, which makes a model of the bone that they can then upload to some software that then can print a model, a real model. And that that process can be augmented by using a software there where you can plan then specific 3D printed guides that you can put on the patient's anatomy that are perfectly fitted to that patient. So it really is patient specific. So we've used this in situations where we have to replace cartilage, where we're going to use a live donor cartilage transplant, where you can 3D print the guides and match them to the deformity so that you can then make the cuts not only on the patient, but also on the cadaver cartilage or bone, so that they're perfectly matched. And there really isn't a lot of room for error when you're doing those types of procedures. So in the virtual world, you can plan those and you can put on those 3D printed guides. You can move them around and size them appropriately for the patient, measure the proper lengths, And then it goes to the printer, and then the printer prints out the guides. And it's at this point that you can fiddle around with it. They print it in a special material for me that I can cut it. So I take it to my shop and cut on it and make sure that everything fits right. So you can really do the surgery virtually once, and then you can do the surgery virtually again, but this time with a physical model. So you can practice, you can wrap your mind around what you're going to try to accomplish at the time of surgery in several different ways, which really helps in the preparation. And then it's just a matter of executing when it comes time for the real surgery. So it's really revolutionized our way of treating complex deformities that we haven't been able to do in the past, with really precise cutting guides that are designed for the patient to get the corrections that we want in a joint that really is unforgiving.
No, and as you said, we're lucky here at Mayo Clinic that we can do this within one facility in the same hospital, and as you said, have these guides for surgery. When you look back now at your patients where you've used these guides, how have you noticed them doing differently compared to, say, when you didn't have this technology available?
Well, in a couple of different ways. Number one, I think it's really decreased complications. So prior to using guides, it was a little bit like opening a present at Christmas. Like, what are we going to see? We had some guidance with the imaging, but our cuts weren't as precise, and so the surgeries took longer. So the complication rate was increased. Because the wound is open longer, for example. So infection rates go up when the wound is open longer. So if you can do an efficient surgery with really precise cuts and not have to fiddle around with making cuts on the cadaver bone and then taking that back to the patient, all the while that wound is open, you can save yourself hours in the operating room, which saves open time, which saves infection rates, or decreases infection rates. The other thing that I think that it really does is it helps to sometimes you don't have to do as large of an exposure if you have a guide. So you can fit it to the end of the bone rather than making a huge approach, which may risk injury to nerves or muscles or tendons around the area. And so I think it's done both of those things and has dramatically increased efficiency. So nerve injury or nerve stretches, which are common around the elbows, particularly with one specific nerve, the ulnar nerve, are reduced. I think our infection rates have reduced, and certainly our operative times have decreased significantly with this technology.
And I'm sure you're also using this technology to treat those patients who maybe a few years ago would have been difficult to treat without these sort of modeling to understand the anatomy and their nuances. And now you're treating more complicated patients where previously that may have been harder to do.
Yes, I think that is definitely the case. So, in cases previously where we didn't have a good understanding or really didn't have much in the way to offer a patient, now we do. We have ways that we can, say, reconstruct or rebuild shoulders, reconstruct and rebuild elbows that have significant bone loss. But it's like everything else. If you understand the problem, then you can understand a solution. And the models have given us that. They've given us a dynamic way of examining these complex deformities that we really didn't have a way of doing before, even manipulating them virtually. And so it's really advanced our understanding and our techniques to be able to solve these problems.
So Dr. Morrey, obviously with all these wonderful surgeries, with the COVID pandemic, how has that affected your practice, and how are you doing things differently for your patients?
I think the more complex patients are coming to Mayo because we are have the ability to solve those complicated problems. COVID has been something that I think has increased the complexity. I think when patients have sort of more straightforward problems, they're staying closer to home, so they're not traveling as far. So I think the level of complexity has gone up in the patients that we see here. I think the way that we're engaging with patients and seeing patients certainly is strained with the masks, the distancing. It's more difficult, I think, on patients, just that human interaction. Just like just like people are having difficulty, with families. They're not able to get together with their families, and I think there's something about the art of medicine and interacting with the patient and seeing the smile and being able to lay hands on and shake a hand, and all of that is different. So it's I've struggled from a human perspective, interacting with patients, because I really like my patients. I love interacting with them, and it's been difficult with the garb. Having said that, it is the currency of the realm, and it's keeping patients safe. We've had an extremely low transmission rate at Mayo and I'm not aware of a transmission from a patient to a physician or a physician to a patient with the precautions that we've instituted. And so I think it's our first mantra is do no harm, and I think that's helped keep everyone safe. It's just we miss the human side of interacting with patients.
Absolutely. Mark, anything else that you want to touch on that we didn't talk about?
I don't think so. Thanks for having me. It's been fun to talk about it. I think I'm excited about it because it's really helped to take patients that haven't had solutions in the past and be able to give them a solution is tremendously rewarding for us.
Thanks to Mayo Clinic orthopedic surgeon, Dr. Mark Morrey. Thanks for joining us today, Dr. Morrey.
My pleasure. Thanks for having me.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on podcasts. Thanks for listening, and be well.